Hello, everyone. Welcome to our podcast. And I'm Professor Mukri Hamdan from the University Malaya Medical Center. And together with me today is Professor Angela Aguila from the University of Philippines. And this podcast is actually uh, is brought to you by the SIG endometriosis and adenomyosis by ASPIRE, which is led by Professor Angela herself. And we are going to talk today with regards to how adenomyosis, which is a non disease that can cause fertility and also cause a lot of pain. And today we are very honored to have our own SIG leaders to talk about adenomyosis. And when before we start, maybe we can ask Professor Angela uh, why is actually adenomyosis really matters that actually can cause fertility.
Thank you, Mukri, and welcome to our podcast. This is brought to you by Aspire Special Interest Group, and we really want to bring you very good discussions on the very controversial topics and very challenging conditions that afflict our patients today. Now, adenomyosis is one such type of condition. Adenomyosis will increase the bulk of the uterus and may interfere with the anatomic relationship not only of the ovary with the fallopian tube, but also hamper sperm transport because a large, bulky uterus may be difficult to negotiate in the point from the point of view of spermatozoa. Additionally, implantation may also be impaired because an inflammatory milieu promoted by adenomyosis may also interfere with the uh, implantation of the embryo, and the crosstalk between the embryo and the endometrium may be hampered with the um, all the cytokines or other problem the other micro what do you call this microstructures that are needed to activate the implantation or docking of the embryo with the endometrium. And last but not the least, women with adenomyosis and some of them with concomitant endometriosis may have sexual dysfunction. Sexual dysfunction prevents them from engaging in regular timed intercourse, and this terribly decreases their chances of conceiving. So, given
Yep.
those challenges, we hope that
Yeah.
we'll be able to answer more.
Adenomyosis is not only one cause of fertility. There are many causes of infertility in patients with adenomyosis. So before we go further, how do we diagnose a patient with adenomyosis, Prof?
Well, before there is a MUSA criteria, and sometimes it's MRI or magnetic resonance imaging that is a way of diagnosing it. But many of our sonologists are able to diagnose it already using the ultrasound criteria. We can see shadows that are characteristic of adenomyosis. One, you can see heterogeneous shadows in the myometrial lining of the uterus. Two, you can see difference in the thickness from the anterior to the posterior wall and vice versa. Three, you can see actually hypoechoic areas or lakes that can be representative of endometrial glands and endometrial material within and embedded into the myometrium. So we now have very good uh, correlation with imaging, and we don't need an invasive method to confirm if there's adenomyosis or not.
Okay, that's good. So meaning that we can actually diagnose it non-invasively, and I think we don't have to do. It's not a surgical diagnosis, of course. And since we are talking about fertility preservation and things, so how would actually make before we do surgically? How can we optimize this patient medically or maybe hormonally for preserving the fertility, Prof?
It's very interesting because most patients may have asymptomatic adenomyosis, meaning they're trying to consult for infertility, but we see that they have potential adenomyosis based on our imaging. So what we do is we just proceed with standard of care in terms of working up the patient for ovulation, for tubal, as well as for male factor. Those are the top three factors. And then once you don't have any other reason why the patient's not able to get pregnant, then consider what we can do with the adenomyosis. Is it interfering with implantation? If it's asymptomatic and it's a possible implantation issue, then an issue will be debulking the uterus, and there are many ways. So, for example, if we can medically debulk the uterus using our hormonal agents, for example, the GnRH antagonists such as leuprolide, triptorelin, whatever you
Mm.
have in your country, we can do
Yeah.
that. If it's still intractable, we have to consider uh, before, this is interesting, surgical methods. It's very tricky to do surgery in adenomyosis
Yeah.
because it's so hard to distinguish normal myometrium, where the normal myometrium ends and the adenomyosis begins. It's good if you have a focal lesion, just as adenomyosis. But if you don't have that, then it's so hard to debug. And the challenge is to preserve the integrity of the uterus for it to be viable to carry the baby. But luckily nowadays, between the medical management and the surgical management, we have non-surgical management. Prof. Mukri is a
Mhm.
very, very strong advocate, and not only that, a practitioner of this, because there are many that we are able to employ, the top three of which is one, uh, HIFU or high frequency ultrasound. Two, uterine artery ablation. And the newest, and the one where we are seeing very promising data, is microwave ablation. So these three
Mhm.
are the ones that show promise in terms of not being able to control the adenomyosis or debulk the adenomyosis using
Mhm.
medical management, but uh, we still have an option before we go into surgical management, because surgical
Mhm.
management carries by itself risks and may not
Mhm.
only harm, not may not help, may even harm fertility.
Yes. That's a really good options that we have since we don't have to go for surgical, so we can have a minimally invasive or very non-invasive intervention that we can use for adenomyosis. And I think nowadays in Asian Pacific region, we are going to have a lot of options for this patient. So, Prof, do you have any I mean, what are the surgical means that after we do the medical management and then we do the minimally invasive management, what are the conservative uterine preserving surgical technique that you probably would be advocating in a patient with adenomyosis?
Well, definitely, it may be helpful if you have a focal lesion. So if it's an adenomyomectomy, the only challenge will be one, where to place your incision in the serosa layer. Two, what extent will you want to debulk the uterus? So we can do gross inspection. Of course, you're doing this by laparoscopy, and try to see where the adenomyotic nodule ends and where the myoma begins, because the myometrium begins. And you can see that by when you have haptic feedback, meaning that may be one advantage of general laparoscopy or usual laparoscopy. You can actually palpate. You have a feel whether it's very thick fibrotic tissue or whether it's very supple myomas or a myometrium rather. So you can try to delineate where the normal and abnormal tissue ends and begins. Now, if you don't have that, then there is what we have recently used, intraoperative ultrasound. So this is not ultrasound where your sonologist is down in the transvaginal route trying to find out whether you're near or far. We have the intra-abdominal ultrasound where a probe fitted with a special contact tip is able to uh, be placed in the serosal layer, and we're able to see where the bulk of the adenomyotic nodule is. And that is a good guidance if you are seemingly lost when you're in the intraoperative phase of the laparoscopic adenomyoectomy. Now, the other challenge, of course, is when you have a diffuse type of adenomyosis and you just have a bulky uterus and it's thick and large all over. So the bulking is a challenge, and most of the issues with regards the complications of adenomyosis surgery may possibly arise. You may have issues where you have uterine rupture eventually or placenta accreta because the extent of your resection is totally unpredictable and you use best clinical judgment. There are no guidelines because uh, there is no clear therapeutic trial as regards this technique. And across the literature, you can see several techniques being proposed, but the outcomes have not been tested using a proper randomized controlled setting.
Okay, Prof. I think that is really insightful, where we have actually a lot of techniques to help us on doing surgical management of this patient. So maybe since we already gone through all the different types of fertility sparing management, so can you give us like a practical pathway on a patient who are going for pregnancy with underlying adenomyosis? What are the practicality from investigating it to the treatment of patient who are planning to get pregnant?
So if you have a profile of a patient who's trying to get pregnant and you have uh, other concerns, for example, the patient has male factor, the couple has a male factor problem or a tubal factor, or the patient already has poor ovarian reserve, then we really emphasize a straight to ART approach or straight uh, ART, because trying to be very conservative, wait for spontaneous conception, and wait for using natural techniques may uh, squander the time and the ovarian reserve of the woman as well as the resources. So when you're gonna do ART, the challenge there will be how to collect the eggs if you have a very bulky uterus. If your uterus is small and your ovaries are accessible, then go ahead, collect your eggs, and create embryos in the lab, freeze them, and then work on the uterus. So once you're assured of a sizable number of embryos to have some reasonable chance of a live birth, your uterus, uh, you will have several approaches. You can do medical management. If your uterus is not so bulky, you just have a thickened posterior wall, for example. We do several rounds, at least 3 months worth of urinary agonists, such as leuprolide. So when it is has decreased in size, or you think you reasonably have controlled the disease, then you can transfer the embryos. Two, if it does not work or you still have a very bulky uterus, refer the patient for ablation using our other techniques. For example, microwave ablation or high frequency ultrasound ablation. And then when you have debulked the uterus using that method, then you can proceed with embryo transfer. Last but not the least, you can do surgery. But again, the surgery is very difficult and sometimes it may distort the uterine cavity, making it more challenging, especially when you're doing embryo transfer. If you have heard cases where the uterus is so distorted, the uterine cavity has been bent, and you're struggling to put your embryo catheter in because somebody did a surgery that distorted the flexion of the uterus. So that's one issue about that kind of surgery.
All
Now,
right.
when you're trying to do natural conception, that's another challenge. And with that, we don't have a pathway that is very clear. And if you are dealing with a young patient, maybe you can be very conservative and just debulk the uterus or just try to make her conceive with the adenomyosis notwithstanding. But be prepared for concomitant pregnancy outcomes that are poor. Miscarriage is a risk, preterm labor is a risk, and even concomitant autoimmune diseases that accompany adenomyosis and endometriosis may cause poor pregnancy outcomes.
Okay, Prof. I think that's really, really, I mean, concise and very precise thing that we can do for patient who are going for pregnancy. So I think for the last 10 to 15 minutes, we have actually covered all about adenomyosis. We know how actually adenomyosis can affect fertility. Prof. Angela also have tell us about diagnosis and how we phenotype them through the latest Musa criteria. And we have discussed about medical and hormonal optimization and how we actually have a conservative interventional pathway for those who are going for pregnancy. I think this all will be discussed in our upcoming fertility sparing management for adenomyosis in my country, Kuala Lumpur. Please come and join us again for fertility sparing management in an inspiring program lineup with lectures. And of course, we have also hands-on training workshop with microwave ablation simulation lab, live demonstration for a live surgery, and also we have a live demonstration robotic adenomyomectomy, and also enhanced on station. So I think, thank you, Prof. Angela. This is very, very short but concise thing. Maybe one or two lines before we end this podcast, Prof.
Thank you. Thank you, Mukri. It's very hard to manage adenomyosis. You don't know if it's going to be the one that is causing your infertility or not. And you don't know which parts will be prudent to introduce your interventions when you have an adenomyosis. So the goal is one, first do no harm. Try to use simple, non-invasive treatment to control the disease. And before jumping into surgery and blaming the adenomyosis for the infertility of the patient, try to explore non-invasive means. That is why we're really inviting you to please go to Kuala Lumpur end of January 2026 because we will be there to guide you, to help you deal with the disease, to learn about all these modalities, including the newer ones, and to find out which of these modalities will be helpful for your patient and how to integrate these modalities in the pathways for your patient's eventual fertility. And hopefully, all of your patients will have one live birth at the minute. Okay?
Yes, that's the ultimate goal, Prof. So I think with what we had today, we know that adenomyosis, even though it actually can cause fertility and pain, but you can do something to restore, maybe hopefully not to worsen the fertility, but restore the fertility by increasing the implantation rate using medical or non-medical management. So I think thank you for listening to our podcast. Is actually a very good short podcast, but I think we will discuss this more on the fertility sparing management of adenomyosis on the 23rd on the and 24th January 2026. We have Prof. Angela herself, Prof. Ching, Prof. Yan from Taiwan, Prof. Zen from Taiwan as well, Prof. Yasushi Hirota from Japan, and Prof. Rashida Begum from Bangladesh, who will share together with our local experts regarding the fertility sparing management of adenomyosis. I'm sure that you will have a very good scientific program offered to you in January 2026, and hopefully that you can see us there in Kuala Lumpur. Once again, thank you very much, Prof. Angela, and thank you
Thank
everyone
you.
for listening, and hopefully to see you in Kuala Lumpur.